We want to get started, so we don't have to pronounce Dr. Levine, but I would like to introduce him today. He received his doctoral degree in psychology in 1989 after completing his internship at the University of California, San Diego School of Medicine. And then his road from there to here includes a 2-year postdoctoral fellowship in neuropsychology at UCSD, where he was a recipient of a Research Service Award by the National Institute of Health. And then serving on the faculty of the UCSD School of Medicine, primarily managing the nation's largest research center focused on the effects of AIDS on the central nervous system. So in '94, he returned to Montana. He's a native Montanan. And he joined the neurosciences department at the Western Montana Clinic. And in 2000, along with partners, they founded the Montana Neurobehavioral Specialists. So now, as a managing partner and senior clinician, he focuses on developmental disorders in children, the concussions and head injuries in both adults and children, and progressive dementing disorders in older adults. He's a native Montana, as I said, and when he's not enjoying flying, fly fishing, cycling, and running, he considers convincing his wife to marry him and not counteracting her great parenting of their children as his greatest accomplishment. So here we go, Dr. Levine.
Thank you. Wow.
Not be anything good going on in Missoula. Listen to a psychologist talk about Alzheimer's and dementia. So thanks for being here. Today we're going to do a 10,000-foot kind of overview of Alzheimer's and related disorders. But I'd really like to make this as interactive as possible. I can bore you all day long with nuances of Alzheimer's disease and related disorders. But if you have questions and we can customize this to your interests, that will certainly be useful. So raise your hand or throw something if you have questions or comments, and I'll give you a good answer or make up a good lie, whichever comes first. My pedigree with Alzheimer's disease goes back to the late 80s and early 90s when I was at UCSD. UCSD School of Medicine was one of the initial sites chosen for the Alzheimer's Disease Research Centers, the ADRCs, if any of you are familiar with the old ADRCs. And so at UCSD, and to this day, it remains kind of the center of most of the really exciting research, along with some places in Boston, New York, UCLA, UCSF, and University of Florida, Gainesville, where the real work in Alzheimer's is going on, and the real questions are being asked and hopefully will be answered sometime here during our lives. So I've got a long pedigree, and that's what we're going to work through today. But again, make sure that you throw up your hand, and we'll take any rapid trail that comes along. But let's define what we're dealing with here, first of all, because simply looking at the demographics of America shows us what we have to deal with. I was just at a meeting about 3 weeks ago with some representatives of the National Institute of Health, and the executive director of National Institute of Health basically said the only concern for the National Institute of Health right now is how not to break Medicare with Alzheimer's over the next 30 to 40 years. They haven't even begun to think about the financial implications of this at a real level yet, because they're still having such a hard time getting their hands around how big this is. I mean, if you just look at the numbers here, we're just starting to see the hamster come through the boa, right? We're seeing the baby boomers move into this older generation. Now, as I get older gets older and farther along. Middle age to me now is like in the 70s now that I'm in my 50s, right? But boy, when I was in my 20s, anybody in their 50s was old already. But by looking at these data, we can see what's happening. The percentage of Americans 65 years of age and beyond has tripled in the last 100 years. It's 13% of the U.S. population, but this is the big one. What's the centenarian? 100 years of age, and that's only going to continue to grow, as you can see. Now, to understand Alzheimer's and related disorders, we also have to understand normal aging relative to non-normal aging. And there's tremendous variability. If we remove Alzheimer's, we remove other clinical pathologies from the mix, there's still a tremendous amount of variability that just occurs as we age. Some of that is due to factors under our control. General health status, our exercise, our diet, mental activity, education, all these things play a role. And then there's this thing called genetics that plays a role. Bottom line is it does have a factor, is a significant factor when it comes to aging. If your parents lived to a ripe old age and were relatively lucid, You're probably going to live to a ripe old age and be relatively lucid, all other things equal. But genetics is not the only factors we'll look at, but it is something we have to deal with, which we need to deal. Now, over the last 60 years, we've really been focused clinically on keeping people alive. It's all been focused on really quantity of life. We ran into a problem in the 90s when people started saying, well, we're outliving our brain, basically, and so we're keeping a lot of people alive, but their brain is aging now faster than the rest of their body. In the 90s, a fellow by the name of Lou Judd, who was a psychiatrist, took over the National Institute of Mental Health. Actually, in the late 80s, I guess he actually got appointed, and he declared the 90s as the decade of the brain. And the decade of the brain, come on in here, don't let us teach it. The decade of the brain did many important things. One, it started funneling more research into central nervous system and brain research than we'd had for the past 40 or 50 years. But even more importantly, there were very bright researchers and clinicians who said, to understand the brain, we can't look at it as a slice in time. We have to look at how does this brain change over time. So the vast majority of the studies that were funded were longitudinal studies, many of them which are still going on through the ADRCs. Because what we want to know is not how do we look when we're 70, but how do we look when we're 50? Does that relate to how do we look at when we're 70? And when we look at 30, what does that predict for when we're 70? Because most of the disorders that affect us and we're dealing with, particularly when it comes to dementia, aren't things that occur suddenly. They're things that occur over time. So some significant changes came along, and we realized that significant cognitive decline doesn't necessarily equate with age. Just because you get old doesn't mean you have to lose cognitive capacity. But having said that, advancing age is still the greatest predictor of cognitive decline. But we have to move from this quantity to quality of life. We need to learn how to age well, not just physically and orthopedically and from a cardiac perspective, but from a brain perspective. Now, with normal aging, mental decline is not due to cell death. Okay? It's not that we lose the neurons, but we get atrophy of connections. Remember how neurons work. They're like trees. You've got a trunk, and off that trunk, that's the neuron. Come the branches, those are the dendrites. And as we age, we don't lose a lot of neurons as much as we lose those dendritic connections. The branches fall off the apple trees. In fact, we can continue to grow new brain cells throughout life. Not the major neurons, but those dendritic arms. And that's something that we now take for a fact, but if you went back 6 years ago, we were teaching the fact that we didn't grow those, and once you lost them, suck to be you, you're out of luck. Now we realize, no, there's a lot that we can do to change that as long as we don't let the neuron itself die. Now let's take a look at just briefly some things that we know are problematic as we age, regardless of what happens. This has nothing to do with whether you have a dementia, whether you don't have a dementia, just what makes your brain age more rapidly. There's some very obvious ones up here. Excessive alcohol use. Don't pickle your brain. It's not going to be good for you, okay? Cigarettes, heart disease, and of course cigarettes and heart disease run together. But what's good for the heart is generally good for the brain. 80% of all the oxygen used every time your heart pumps is used by your brain unless you're in some sort of exercise or aerobic condition. It is an oxygen hog. It is such an oxygen hog that it will actually sacrifice other parts of your body to preserve blood flow and oxygen flow to the brain. If you're bleeding profusely, it will shut down the arteries serving one of your kidneys because it knows you can survive with one kidney in order to keep perfusion going to your brain. It's a remarkably designed organ, and it's all about self-preservation, which results about us preservation. Because you lose other parts of your body, you survive, you lose your brain, you're kind of out of luck. Head injuries and concussions. This is big. Everybody always asks, why are we making such a big deal out of concussions? Well, 2 or 3 weeks ago, we did a thing on sports concussions here. The reason we make a big deal out of it is we now know it's not very good for the brain. It's not how big they necessarily are, it's the accumulation of them over the years. It seems to be associated with an increased risk for less effective aging, yet alone what that immediate effect is. Sleep disorders. Huge. Everybody says, why are we doing sleep studies on everybody now? Because if you aren't breathing when you're sleeping, it's not good for your brain. If oxygen levels drop, we lose neuronal connections, and we can lose neurons, and then we don't get them back. So sleep disorders are very big. Diabetes, we'll talk about that later. Hypertension is big. Medications we look at. Some medications, and this is particularly important as we age, medications that we're on when we're 50 may not be the same level of medication we need to be on when we're 60 or 70. And that's less of an issue now in communities like Missoula, Bozeman, Billings, but it's still amazing. I saw a gentleman just yesterday who came from a little town in eastern Montana, and he's been with the same physician for about 35, 40 years, and the amount of medication that he's on now to control his pain should kill a horse. And it was probably fine for him when he was in his 50s and 40s, but now that he's in his 70s, 80% of this guy's problems are probably related to the medications he's on. I almost fell asleep sitting next to him. Autoimmune disease. This is new. There's some very interesting research, if you've been following the research, on how rheumatoid arthritis and some of the autoimmune disorders seem to be associated with increased risk for adverse aspects of aging and even Alzheimer's disease. We'll talk a bit more about that. And I'll throw this out, anesthesia. This got everybody's attention a while back. It said, oh, if you undergo anesthesia, particularly when you're older, it really increases your risk for Alzheimer's disease. Well, no, you have to be careful with the statistics. It does double the risk, but that risk is still very, very small. And a newer study suggests that's probably not the case. There were some problems with the initial study that didn't take into account why you were undergoing anesthesia. And the bottom line is if you need a surgery, you need a surgery. Don't die of heart disease while trying to preserve your brain, right? I mean, it's commonsensical. But at the same time, what we do need to be thinking about is if somebody is going to have 2 or 3 surgeries in a fairly short period of time, you need a hernia repair, and you need a knee replacement, maybe we need to do that under the same anesthesia if we can, rather than putting you under, bringing you out, putting you under, bring back out. No clear answer to those questions yet, but we're starting to think along some of those areas. Now, let's get to the bottom line, dementia. What is dementia? Okay, it comes from the Latin term, and it's an umbrella term. Okay, when we're talking dementia, we're saying like the cold, the flu. It's a very broad term, but it comes from Latin meaning demons, out of one mind. It's always going to be acquired, persistent impairment, generally involving memory, but not always. Used to be that it had to involve memory. It no longer does according to new diagnostic criteria. And it's usually progressive. Why do I say usually? Well, because you can have a dementia from a head injury, or you could have a dementia from a stroke, and it's not necessarily going to progress all that rapidly. It will with advancing age to a certain degree, just because there's normal changes. But most of the dementias about which we worry clinically are progressive. Now, as I said, dementia is associated with advancing age, but this is not age alone, okay? This isn't normal aging. You don't just normally age into a dementia. Something clinically, some clinical pathological process begins that results in a dementia. Now, is it Alzheimer's or is it dementia? Depends. Dementia is the umbrella term. Alzheimer's is one of the many causes. But you can see we have all sorts of dementias. We've got Alzheimer's disease. You'll see it abbreviated AD or SDAT. SDAT is the term for senile dementia, Alzheimer's type, AD just Alzheimer's disease. Frontal degenerative disorders, Pick's disease, frontotemporal dementia, FTDs. We will see those not infrequently. Mixed dementia, multi-infarct. If you've known anybody with multi-infarct dementia, they have a series of small little strokes, and they keep going down further and further and further and never quite recover after each one until we finally have a dementing disorder. Slow virus disease, Jakob-Creutzfeldt, or Creutzfeldt, Jakob, depending on whether you're European or English, American. Toxic and metabolic effects, Lewy body dementia. Lewy body dementia is whole different horse. We won't talk about it in great detail. We're seeing an uptick in it, at least in western Montana for some reason. I don't know why that is. It probably just is, they come in waves. But it's similar to what we see in Parkinson's disease, but this actually begins before we see the Parkinsonian signs. Is also associated with visual hallucinations and other alterations in mental status. And those are our cortical dementias, which mean they're predominantly affecting the outer portion of the brain. But then we've got all of our subcortical dementias, from Parkinson's disease, Huntington's disease, PSP, hydrocephalus, HIV, and I put depression down here. simply because it's often mistaken for a dementia as we age, and we'll talk a bit about that. Multiple sclerosis can also result in a dementing condition, but Parkinson's does as well. A lot of people, we think about Parkinson's as predominantly being a motor disorder, right? For a good number of those folks, they will progress on to the point to where they have a dementing condition on top of their motor difficulties. But here's why Alzheimer's is important, is because it accounts for 60 to 80%, depending on which study you look at. The largest studies are now suggesting closer to 80%, simply because that jump from 60 to 80% means we have mixed pathology, but Alzheimer's is playing a significant role. But you know, the way biology works is just because you get one thing, it doesn't protect you from another thing. So you get Alzheimer's disease, you can also have little strokes that occur. If you have Alzheimer's disease and you fall and hit your head and you have a subdural bleed, we're adding to it. So bottom line is, if I wanted to be right the vast majority of the time, if anybody over the age of 65 came into my office and they had memory impairment and cognitive impairment at a significant level, and I simply said, you have Alzheimer's disease, I'd be right 60 to 80% of the time, just because statistically it's the most common. So it's what we focus on, but dementia and Alzheimer's disease. Alzheimer's disease results in a dementia, but not all dementias are due to Alzheimer's disease. See the difference? Not that anybody cares, but I do. Yes?
Yeah, my mother's 94 now, and I don't know when her memory didn't start. I think she's like in the second stage of dementia, but when I look at all those different things that you could have, she doesn't fit in any of it, but is there a way she could have I mean, her short-term memory has just gotten really bad.
Mm-hmm.
She knows who I am, but her long-term is really good, but how do you find out what they do have?
That's through complex diagnostics, and we'll talk a little bit about that. But one of the other things to keep in mind is everybody will say, well, they can't have Alzheimer's disease because they can remember something from when they were in the 3rd grade. No, you'll generally have remote memories well into most of these dementing conditions, particularly the cortical ones. These predominantly affect what we call anterograde memory, information for new material that you're learning. So my mother, who is 86 and has moderate Alzheimer's disease, will ask the same question 3 or 4 times in literally a 15 to 30 second period. You look for her keys in her purse, and you'll say, yeah, they're there, Mom, and then, are my keys in my purse? Yeah, they're in your purse, Mom. But she could tell me who her teacher was in 2nd grade and what color the flowers were when she came into the classroom the first day. So that will start to fade, and she's now starting to lose some of that, but it then starts at the newer memories and works backwards. So she's now starting to forget some of her grandkids and who they are, but you still go way back here. Those memories are still very stable. So cortical dementias, we have what we call these retrograde and anterograde lapse rates, which is how memory lapses this direction and then starts and lapses back. Now, this is interesting. The cognitive impairment dementia rate is actually on the decline in terms of rate, okay? But as an absolute number, it is still an issue. We've gotten better over the last decade at trying to slow the progression to dementia and Alzheimer's disease, but it is still growing. This is probably due to higher education, improved medical care, all of these other things that you see here. It's not any one thing, but we certainly have seen a change over the last 10 to 15 years. Now I want to put this up here just because, remember I said age is not the primary factor, but age is a factor. You can see here, green is basically mid-60s and 70s, only about 2.5% meet dementia criteria. By mid-70s, we're up to about 7%. By mid-80s, we're up to almost 25%. You get up into your 90s, and it is up to, depending on the study you look at, 50 to 60%. Now, common rule outs. Remember I had depression on that slide earlier? Pseudo-dementia is something we talked about. So this is memory impairment and cognitive impairment as a result of severe depression. I'll see this very, very routinely. Somebody just loses a spouse because we're not designed to lose spouses. You know, it's hard. You've been with somebody for 50, 60 years and suddenly they're gone. That's a big adjustment. It often sets off depression, even more so than spouse. What do you suppose sets off depression in older individuals? Loss of children. Because our DNA really isn't designed to lose children. We're supposed to die before them. And so often somebody will come in with what looks to be progressive decline, and you look at them and say, oh, they've got severe depression, treat the depression, the cognitive issues will go away. So we look at that. Late onset psychiatric disorder, and then metabolic dementias, like I was talking about with the gentleman yesterday. They were convinced he's depressed and ready to go into an assisted living center, and I think in about 3 weeks, when his brain is off of enough benzodiazepine to put a large elephant to sleep, he will probably be absolutely fine again. Acute stress reactions, hearing loss. This is a biggie here. We lose our hearing as we go across time, and then people start asking questions, and everybody assumes they're demented when really they just can't hear you. So of course they're asking you the same thing all over again. And this is particularly true for men. I'm sorry, men, I'm going to have to pick on us a little bit here, but we're not very good at saying I didn't hear that. Will you tell me? So we just smile and nod and act like we know what's going on. It's worked for me for 55 years. It's not a bad thing. I'm just saying it's reality. But then we really don't have a clue what was going on, but it's not because we forgot, it's because we never heard in the first place. We do hearing tests routinely, and it's amazing the number of times that comes up. But we also do some other assessment, because sometimes it's not hearing per se, but it's auditory processing. They might be able to hear in a quiet room when there's nothing else going on, but if the TV is going on and somebody is trying to talk to them, their brain can listen to the TV or it can listen to the conversation, but it can't listen to both at the same time. And simply taking care of that often makes a big difference. But bottom line, we still have a big problem. Here's a U.S. mortality rate by age and the risk of dementia, incidence of dementia. And you can see as we get older, it simply goes up. This is for females, death of females, death of males. You can see down here, basically 15 to about 25, we have more males dying than females. Why? Because guys are dumb. We do really dumb things in adolescence, and the things we do that are dumb tend to get us killed more frequently than what women do that are dumb. I'm not saying you're any smarter than us, but at least you show a little more judgment in the dangerous things you do during adolescence. And so we have gunshot wounds, we have assaults, we have automobile accidents that have pushed that up, but you can see those rates are fairly concerning. You don't have to be a statistician to say that's a pretty steep curve. And in fact, now how much of this is a problem with Alzheimer's? Well, 5.3 million have it this year, and it will be to 16 million by 2050. Do the math. That's a tripling of it in the next 3-4 decades. That's pretty concerning. It's the 6th leading cause of death, and it's the only cause of death right now in the top 10 that we can't fully cure or can't fully prevent. Heart disease we can manage pretty well. Cancer we're managing pretty well. Diabetes we're managing well, but we're still way behind the 8 ball when it comes to Alzheimer's disease. Just a few more statistics here. I don't need to read them to you, but the bottom line is it's a problem, and that's why the executive deputy director of the NIH is saying this is a big issue for us. Does seem to involve women more than men. This is an interesting question. If you would have asked me this question last year, I and most everybody else would have said, it's just that women are living longer than men on average. We've now had 2, and another study is just getting ready to come out that was just presented showing that now, even when we adjust for death and we adjust for other medical illnesses, women still seem to be preferentially affected. There seems to be a higher risk rate. We think it probably has a genetic component. What that is, you know, if I could answer that for you, I'd be fly fishing on the Pew Creek right now having this conversation with you because I'd have the Nobel Peace Prize for medicine. As you can tell, I'm still here. Now, I talked about the rate decreasing, but look at that top figure. From over the last 16 years, our death from Alzheimer's has increased 89%, while other major diseases have decreased. Now, this 89% is actually a very conservative figure, because rarely on someone's death certificate does it say they died from Alzheimer's disease. Because you die from pneumonia, you die from choking, you die from a fall, you die from exposure, you die from some other event, which is what whoever the physician is that sees you at the time that you die is going to put down. But in reality, we know a large portion of those deaths were directly related to the dementing condition, which resulted in that. I mean, ultimately, the reason you died is your heart stopped beating, right? But we don't just put down heart stop for people, but we're missing a lot of the people for whom the primary trigger of the death was Alzheimer's. And you can see the costs here. We're talking billions and trillions of dollars. So we, as I'd say in Eastern Montana, we ain't talking chump change. This is a huge, huge cost. You know, and from the family perspective, it's huge as well. The amount of, I'll just speak from personal experience, the number of hours my wife has put into getting assisted living care for my mother to get coverage and things like that. It can drive you to drink. Yes?
Yeah, one more question of you. Can a person, if they were really, really severely depressed, could that actually cause a short-term memory loss when they got older or not?
Not permanently, generally. But if you have ECT, like electroconvulsive therapy, it can certainly affect memory. But depression will not generally result in permanent damage to the neuron unless we have something else that comes along.
Right, but if you treated the depression, would it?
Then memory should improve.
It should,
Yeah,
okay.
yeah. Now, to give you an idea here, these are some neat pictures. Because I said this isn't just normal aging. Here's a 70-year-old brain of a person with no clinical condition. And you can see their brain looks pretty normal. If you don't know what a normal brain looks like at 70, that's what a normal brain looks like. This is a 70-year-old with Alzheimer's. And see how the sulci and the gyri are disproportionate to what we see here? What's happened is the brain has shrunk. The good Lord made the brain to where it's a closed system. So if we lose neurons and it starts to shrink, what the body naturally does is it increases the manufacturing and production of cerebrospinal fluid to offset that pressure increase. So when we look at MRIs, what some people say is we see atrophy. Well, what we're seeing is we're seeing more cerebrospinal fluid relative to the amount of brain material that's there. And so we know something happened because there's less brain and more CSF. But here it is, and you're looking at it, and you can see a big difference, two 70-year-olds. Now, what's interesting about this is these two people are identical twins. Not only were they raised in the same place, but they lived next to each other as adults, and they worked in the same business. All of their environmental, all of their other issues, very, 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 very similar. They even married sisters.
Wow.
So, something happened to unlucky number person B here. Here's a PET scan of a normal brain and an AD brain. Now, what is a PET scan? Positron emission tomography. This is something that doesn't show structure like an MRI does or a CT scan does, but it shows us how neurons are functioning. And basically, the brighter the color, the more activity. Okay? Here is that 70-year-old normal brain on a PET scan. Lots of reds and yellows. Okay, so lots of activity in the brain. Here's the brain with Alzheimer's disease with cool colors, meaning far less activity. So it's not just that we're seeing some sort of structural change, there's a big functional change. Even the neurons that are there aren't doing what they were doing, or were supposed to be doing. Let's not worry about that one. Here's an idea, here's a good example as well. This is an individual who progressed with Alzheimer's disease over the course of 2.5 years. You probably all heard, or if you haven't, you took some of your doctor, they may have done what's called a clock drawing test. It's been around for years and years and years. It came out of Boston, Edith Kaplan. But it used to be one of the hallmarks for diagnosing Alzheimer's disease because visuospatial problems are so common as an Alzheimer's disease. So we basically say, draw a clock and set the hands to 10 after 11. Here they are when they have mild cognitive impairment, and they first present with some concerns about memory, but they're still functioning absolutely fine on their own. Here they are basically a year and a half, it was about 16 months later, and you can see how the visuospatial aspects are going. And here they are 6 months later, and here they are another 6 months later. You can see how visuospatial planning, understanding even how to set time goes down. So this is truly a functional problem. It's not just that we see it on images. Now, how do we diagnose this? That was one of the questions. Well, it can be readily diagnosed anymore. It can be made with about 90% certainty. It used to be the only certain way we had to diagnose it was with autopsy. However, that's even now being called into question, which we'll talk about in a minute. But right now it's a two-step process. We do a cognitive evaluation. I can detect under a cognitive measures early changes, what we call mild cognitive impairment, 7 to 10 years prior to clinical symptoms. Some data suggest that's about 12 years, and I would say it's usually 10 to 12 years. And this is particularly important knowing what we now know about genetics, which we're going to talk about. But bottom line is, we do this well, we could have almost a decade head start before this becomes something that's interfering in everyday tasks and activities, which, if you remember back to the beginning talk, I said had to happen. This has to interfere, okay? Now, we get this through confirmation through history, and why do I say history? Because we see slow changes, we don't see sudden changes. If you see sudden changes, you probably have a stroke. Nothing happens fast with Alzheimer's disease. Frontotemporal dementias are also progressive, but they tend to move faster than do Alzheimer's disease. And now, why lumbar puncture? Well, because we look at some certain peptides and other things in the CSF, what we call biological markers, and by looking to see where these are, we can basically increase our likelihood of being accurate in the diagnosis. So we're looking at amyloid beta, 42 concentrations, and we see less of that in the CSF, and that's thought because now it's showing up in the brain, these things we call plaques, which we'll talk about. We see high levels of a protein called tau, which seems to be associated with an increased risk, and that's because as the neuron dies or is impaired, it seems to be releasing tau, and so we're finding it in the CSF because it's not where it should be. So if we put these two things together, and we added nothing else to it, we still had good sensitivity and specificity. We caught 87% of the cases that were going to progress to Alzheimer's disease, and it ruled it out in 95% of the ones that didn't. And when we put those together with the neurocognitive measures, we're at about 96, 97% of the time we'll be accurate, and we'll miss it only about 92 to 93% of the time. And newer data suggests we really didn't miss it in those or we didn't make a misdiagnosis in those other cases. It's just they had something else going on along with the Alzheimer's disease. So really, diagnostic sensitivity and specificity are quite good at this point. But it takes some work. And the biggest problem clinically, again, is not that we can't detect Alzheimer's disease, it's also detecting what else is often there. Because we don't see clean patients. People are messy. So you see somebody who had strokes and develops Alzheimer's disease. That's what makes it difficult clinically, is we're trying to figure out what is due to what often. There's a new biomarker from a blood panel rather than CSF, because lumbar puncture, anybody here ever had a lumbar puncture? Hopefully not, because they're not particularly fun. Somebody has, they're not great. I mean, they're sticking a needle in your spine and pulling out the fluid. It's not a particularly comfortable procedure. The new blood marker will be much, much easier, and it had good sensitivity and good specificity as well. There's some things to be worked out on this yet. I think in the next 2 or 3, 4 years, we'll probably see Centers for Medicare Services approve this as a particular assessment process. Ultimately, as docs, we can't do anything that CMS doesn't approve. Well, you can do it, you just don't get paid for it. So you generally aren't going to do it. And you can get sued for doing it if it's not evidence-based. So hopefully we'll see that come along, because it's sure much easier to take a blood sample than it is a CSF sample.
What's the time interval here between doing these tests? How long has this been followed?
Good question. On the Shaw study, they basically followed folks. They did CSF and they followed them for 5 years to see who was going to convert into Alzheimer's disease. This study was 5 years as well, but both of those studies are also ongoing. So they're actually also following other folks who were younger. And the idea, remember how I said they're doing that longitudinal research? That's the cool, sexy stuff about this, is we're saying, okay, but what happens when we stretch this out even further?
Do those numbers change?
They get better. Yeah. They basically are showing us that the Now, let me rephrase it. They get better over about 5 to 10 years. If we go back further than that, we lose our sensitivity and our specificity, but that's because the pathological processes probably haven't gotten to the point yet to where those biomarkers are even present. And so right now it looks to be a kind of a 5 to 10 year window that we're shooting with. There are a couple of other biomarkers now that suggest we can go back further, but because of some other recent changes in the research findings, that we're going to have to see what happens to those. I'm going to talk a little bit about that in a minute. So some things we're real hopeful for, we're less hopeful for. Now, screening evals. How do we detect this if there's a concern? Well, first of all, see a general physician for general medical care. Make sure nothing else is going on. Because if you're hypothyroid, if you're anemic, if you got something else going on, there could be cognitive concerns. Urinary tract infections, particularly in older folks, often result in cognitive changes. So see your general medical physician. But here's the important thing. Self-reports of decline in function are important. 5 years ago, we would have said, nah, it's worried well, don't pay attention to complaints. If somebody says that they're having cognitive changes, it's probably because they're depressed or they're anxious, it doesn't have any outcome. We now have, a dozen studies showing, no, Tonto, back up the horse, we're wrong. There may be folks that are indeed complaining, but the vast majority of folks who complain are indeed picking up on those early changes. And so we now take those complaints about cognitive decline very, very seriously. And we're trying to get primary care to particularly pay attention to that, because some of the older primary care docs are still of the model of, no, if you're 60 and you're telling me you have cognitive complaints, it's just because you're 60. Now, most of us, believe it or not, do tend to be pretty good observers of our own behavior and are aware of when there are changes. So it's not as simple as saying, no, we're not going to pay attention. Sure. Now, if everything checks out medically, we don't see any real problems with metabolic studies, other illnesses, and you've got complaints, generally a referral is going to be sent to somebody like me, and we'll do brief testing that takes about 3 to 4 hours, and that's the real sensitive testing that can usually help us identify this 7 to 10, maybe 7 to 12 years prior, is what we call mild cognitive impairment. So you can be in this category called MCI. Now, not everybody that has MCI is going to carry over to a dementing disorder, but part of our job is to try to catch people at that MCI stage and not let you get to that point. Right now, if we took 100 people with MCI and we followed them over 5 years, about a third would move to the point of Alzheimer's disease or another dementing condition. About 2/3 wouldn't. So the statistics aren't all that bad. But yes, I saw a hand.
MCI?
Mild cognitive impairment.
Yes.
Yep, mild cognitive impairment. So you aren't quite normal like your age-matched peer, but you're not at the level of a dementia, so you're somewhere in between there. It's like a fever of 99.5. Okay.
If you find your doctor is ignoring your complaint, you switch doctors?
No, what I usually say is, give me a referral. I know you don't think this is a concern, but I have a concern, and most physicians are then going to be very good about it. They're also trying not to over-refer because they don't want to, create a problem where there isn't one. But if it's a concern to you, say, for my sake, can I get an evaluation done? And for reasons we'll talk about later as well. And most of the time, they're going to be pretty good about it. Yes?
I had a dementia diagnosis. Where do I go to get a second opinion?
Well, it's hard to say because it depends on the type of dementia, but generally you're going to end up seeing either a neuropsychologist or a neurologist, and if you see the neurologist, they're usually going to refer to the neuropsychologist. So you end up seeing somebody, in bigger cities you could also go to a geropsychiatrist, but we don't have a geropsychiatrist. We're lucky to have psychiatry in Missoula, you have no geropsychiatry, and we're lucky to have neurology in Missoula. We're losing one of the best ones I just heard yesterday from that. So basically, you end up seeing me or Dr. Harrison or my colleague Dr. Pierce for right now, or John Schaefer in neurology, who's usually going to refer to us or share a lead in neurology.
And you're backed up?
I'm so backed up I could die now and die. But all the patients we see are seen on a triage basis. And so people say, well, you've got 300 and some or 280 some people on the waiting list. Yeah, but some of those are folks that there's nothing urgent about it. Dementias, things like that, we tend to get going much, much earlier because those are things that are time sensitive. Saying, well, I'll get to you in 2 years when you have a process that could result in you being dead in 6 months isn't a real good idea. So if somebody's got something that we're concerned about that's more urgent, they get seen sooner. Dementia, because they're progressive conditions, we get them in sooner because there's a lot of things we want to be doing. We got to get busy. And then we do all the coordination with primary care, radiology, neurology is needed to help rule out other causes. And make sure there's not something going on, and that's the real key, make sure there's not something else going on that's going to magnify the rate of progression with this. The standing joke in my field is the way we cure your Alzheimer's disease is by making sure you die of something else first. Bottom line. Because we don't have a cure for it. My goal is to make sure to blame your cardiologist when you go. I'm going to say, yeah, they're dead, but they remember your name. We're fine. So take that, cardiologist. Get the pump again. I got a whole brain to deal with. They did fine. Now, the question, and I get this from physicians a lot of time, well, because we don't have a cure, why bother knowing? Why bother knowing? All it's going to do is worry people. Well, to understand this question, we have to understand what it is with which we're dealing. So let's take a look at something. Now, this is where things get a little technical. Okay, I'm going to go through this fast because otherwise I'm going to cure all your insomnia. But this is also important to understand because it's the foundation for where the real interesting and sexy stuff is coming. So we've got to look at some basic neurosciences here. Now, the most fundamental aspect of Alzheimer's is that it affects the neuroplastic processes, the way these connections are happening between neurons. And by understanding where the basic breakdown is, we can find ways to intervene, or at least hope we can. Now, as far back as '68, Blessed and his colleagues found that, and we still believe this to this day, although we're questioning some things, that the basic pathophysiology associated with Alzheimer's disease has to do with what we call senile plaques and neurofibrillary tangles. We look at the brains on autopsy, we see these amyloid plaques. Amyloid's a protein, and it's basically causing these big globs. And then neurofibrillary tangles is where we have these little, if you will, look like vessels, but they're not carrying blood, and they start to tangle up. Something goes wrong with the neuron, and they start choking themselves off. And back in the 60s and all the way through, we're all saying in Alzheimer's disease, we have more senile plaques, and we have more neurofibrillary tangles. And so they're involved, they're playing a role. Now, the senile plaques are formed from something called beta amyloid, or if you're English, you can call it amyloid beta. It depends on which side of the pond you're from, as the British would say. And what we think is that amyloid beta in these senile plaques are more closely related to the cause of Alzheimer's disease, or at least has been our thought for the last 30 years. Then neurofibrillary tangles and tau, which is another protein that's associated with it, remember we were looking at in that CSF, we thought was due to severity, probably not causation, but now there's some question about causation. But originally we thought, okay, amyloid beta causes NFTs, then determine how fast it goes. Now, there have been several theories beyond that. One of them is the cholinergic hypothesis that Alzheimer's disease, even though we've got these amyloid plaques and the NFTs involved, it's really due to a reduction in the creation of this neurochemical called acetylcholine, and that's what all of our medications to date have been focusing on. Donepezil or Aricept is the brand name, or Namenda, which is memantine. There's 3 or 4 of them out there. But quite frankly, I hate to say this in its crass, but these medications suck. They really are not very useful. They, yes, can provide some symptom benefit for a short period of time, and we use them because because they can provide some symptom benefit at certain stages, which can make it easier on families, make it easier on patients, and maybe even keep somebody independent for a longer time. But what we have been sorely disappointed with is that they have nothing to do with whether the disease progresses or not. So if we put you on a medication and we can kind of limit your symptoms, it's ultimately going to break through, and more importantly, if you withdraw the medication, you drop right down to where you would have been if we didn't have the medication. So it's not fixing the leak, okay? So we use them, and I'm not saying they're bad, they're not curative. They're not protective, they're just providing some symptom control for a short period of time, and really have been unimpressive in the results. Now we go back to our amyloid beta hypothesis, because everybody knows amyloid's involved somehow. We see that in Down syndrome, where they have some extra APOE4 alleles, and we'll look at that allele later. The downside is our medication trials, including 3 very recent failures from drugs that if you would have asked me this 6 months ago, I and everybody else that would be up here in front of you would say we are so hopeful because early trials look so good, including some European trials, have now miserably failed. We cleared plaques, and there was no change in cognition. So something else is going on here. And I just talked with a pharma rep last night, and she says, people are always saying, oh, pharmacy knows how to cure, big pharmacy knows how to cure Alzheimer's disease, they just don't want to do it. Mm-hmm. To which she said, if they only knew how many billions of dollars we just wasted on these trials, and now we're starting all over again. Now, there's been some question, has maybe the lack of the amyloid beta focused medication been a timing issue, or we're not getting them fast enough? And that drum is still being beat, and I think there's reason to still beat that drum, but the problem is our most recent failures were already studies that moved that intervention point back further. So time will tell. Tau is the other thing. Again, we found some interventions that affect tau. We make changes on how we measure tau. Everybody goes, woo-hoo, look at that, we changed it. And then we look at your clinical functioning, and we say you're just as bad as you were before, and it's continuing to progress. So tau hasn't provided us any sort of marvelous response. Now, this is a very busy slide, but I'm putting it up here just to try to illustrate that this line here is amyloid, and this is still what 70 to 80% of all of the research, funded research, is looking at is amyloid beta. Okay? And we know that it increases, and this is where mild cognitive impairment starts, this is where dementia starts. And so we know amyloid rises, and initially when we did the medication trials, we were out here, so everybody said, okay, we just have to be back here. But that's where we were with those ones that just failed. So the next step is now to say, what happens if we come back here? The problem is trying to find ways to catch that amyloid in people before they reach this point. So I think there's still valid argument saying amyloid is important, but by the time we get to the point that we're measuring with most people, the damage has already been done, the poison's in the well, so you're not going to get it back out. So we'll see if backing it up further helps, but I'm far less hopeful now than I was 6-9 months ago. In fact, last spring, I'll be giving a lecture at the university Thursday. Last year, Thursday, I was saying, I think there will be a cure to Alzheimer's disease, or at least a very significant treatment for Alzheimer's disease in my lifetime. This year, I won't make that statement. I'm hoping, but I'm hoping against odds, at least from a medication perspective at this point in time. That has not reduced my enthusiasm. My enthusiasm about managing Alzheimer's disease has actually increased, because this set of failures has caused neuroscience to reconsider some of their basic understandings of Alzheimer's disease and ways we might intervene. I've already talked about that. We've talked about them failing, but we're changing the way we think. So where does this leave us? Well, let's now take a look at what we do know that seems to be holding true, since the amyloid beta tau kind of pathology issue is all in question, and we're saying what we thought we knew doesn't apply. What can we look at in genetics and epigenetics may be where this is all sitting at this point in time. So let's look at the epigenetics. The genetics. What do we know about the genetics of Alzheimer's disease? And this is important because one of the most common questions I will get from the younger people is, my mom had Alzheimer's disease, so am I going to have Alzheimer's disease? Well, now, not unless you have familial Alzheimer's disease, then you're out of luck, but nobody in this room has familial Alzheimer's disease for the most part, or you'd already be in a clinical study, because we know who these people are for the most part. And so I've yet to find anybody in Montana in the FAD studies. We are part of not the mutation that results in familial Alzheimer's disease, but variations in the genetics which increase our risk for Alzheimer's disease. Yes?
Do they know whether or not there's an association with maternal or paternal genetics?
Good
or is it
question.
equal?
Good question. We don't know. Like I said, we know women tend to be involved more, but we don't know whether it is more heritable via maternal versus paternal genes. We don't know. And we haven't even gotten to the point of understanding the basics well enough to start looking at the gender effects yet, to be quite honest with you. But what I have started to identify are some risk genes and some protection genes. There's been 9 genes identified over the last 2 decades, SPON1 as being one of them. This is associated with a weakness at the synaptic level. Remember where those neurons talk. And it's also related to beta amyloid aggregation. So I and many other people are starting to say beta amyloid may not be the issue. Beta amyloid is the marker of something else that has happened upstream. And so then when we don't clear beta amyloid, it shows up, but now the spot's already on the table, so taking the spot out doesn't still take care of that upstream problem. The hope is that if we can figure out what SPON1 is doing, we might be able to kind of turn off that gene that's resulting in loss of these dendritic connections in amyloid aggregation. The most common gene, the one that's most studied, is in this realm, the APOE gene. There are 3 primary isoforms in genes, APOE2, E3, and E4. And you don't need to understand the genetics. All you need to know is if anybody says, do you have genetic testing for Alzheimer's disease, this is what they're talking about, the APOE4 allele, because it seems to be the one that is the highest risk gene. If you have APOE4 allele, you're at higher risk than you would be if you didn't have the E4 allele. But it's not a one-to-one correspondence, okay? It can account for the majority of Alzheimer's disease risk and pathology, but most risk is still not literally genetic. Look at that, 40% with Alzheimer's disease have the gene, but 60% don't. And based on the conversation I had back at NIH with some marvelous neurogeneticists just 3-4 weeks ago, it's even more interesting because if you have the APOE4 allele, but you also got a protective gene, you're at lower risk for Alzheimer's disease, it looks like, than if you didn't have the APOE4 allele, but you didn't have the protective gene. So the genes are very, very complex in the way they're there. But if you have 2 of those genes, we're going to watch you a lot more closely. And frankly, what I tell people is if you have cognitive issues and you have 2 alleles, let's just treat you as if you're going to have it. Let's do everything we can early on. It's not going to create a problem to keep you from developing that risk. It's like if you have diabetes in the family. We're going to watch your exercise, your weight, and your diet real early on so you don't develop it. Other ones that are looked at, I'm going to throw these out here because we might talk about some of these later, but presenilin and presenilin 1 and 2 are important, primarily because of some things that have to do with diabetes, which we'll talk about. Now here's what I was talking about. We got ahead of ourselves here, but familial Alzheimer's disease isn't what we're going to be talking about here. There's a family in Colombia, South America that this has come through. There's a family in Western Europe that this has come through. These folks generally develop Alzheimer's disease very early, 30 to 50 years of age. If you have the gene, sucks to be you, you're going to get it. Some will develop it later, but it's not a matter of if you get it, it's a matter of when you get it. This is almost a one-to-one correspondence, kind of like the Huntington's disease gene. It's what we call a mutation. If you have that mutation, you're going to have it. We're talking about variation in genes, and that's what most of us will deal with. Now, not just risk genes, but we've got these protective genes. This DRD47R protection gene is very, very important. And one of the things we've seen is that this is present at a very high rate in people who are 90 years of age and older, and even the higher rate in our centenarians. Okay. So if you have this, it seems to increase your longevity, but not just physically, it seems to increase the longevity of your brain's ability to withstand effects of age. The other thing that's interesting about this, though, is that it seems to primarily mediate its effect by making people more motivated to pursue social, intellectual, and physical activity. And so the question is, are we living longer because of this gene, or are we living longer because this gene gives us personality traits to be more active in all of these realms, which then allows us to age and live longer? And the data, wait for the drum roll, suggests that, yeah, that seems to be it. And that's why I'm not all that disappointed about some of the pharma trials failing, because we're now starting to get some interest looking at some of these other areas, and they're looking remarkably impressive. SIRT3 is another protective gene that's there. This one, I think, holds some real promise. It doesn't change our motivation, our behavior, and so on and so forth, but it seems to change the way our stem cells function, which may slow the general process of aging in cells. So if we now look at that protective element with some other lifestyle changes, we really might be putting together a powerful package. Now remember, I talked about those PSEN genes. Insulin is now showing up on the radar screens that relates to Alzheimer's disease. We know that if you have diabetes, your risk for Alzheimer's disease goes up. If you have type 2 diabetes, it goes up. Type 1 diabetes goes up. Even pre-diabetes. In fact, there are some articles in literature that now refer to Alzheimer's disease as insulin type or diabetes type 3. We know that insulin is playing a role, and in a little study, treating folks with 20 to 40 international units of intranasal insulin per day seemed to really help. They didn't decline. So clearly the glucose insulin factor is playing a role. And here's a nice little, you can't see it real well with the light, but what you can see here is basically these are the arms coming off of the neuron. On the left side is a non-insulin treated neuron, and on the right side is an insulin treated neuron, and you can see how many more connections we have in this one versus this one over here. That's all you need to get from that. It seems to be playing a role in maintenance of the branches of the tree. So, what does this all mean? Well, now we know a little bit about some genetics, just enough to be dangerous. Okay? The studies are still going on. But the most exciting part, I think, of science right now isn't genetics, it's epigenetics. If I could go back, I told my wife the other day, honey, you gotta support me and be a sugar mama, because I want to do two things in my life. I want to get a PhD in behavioral economics so we can figure out how to change people's behavior before there's a crisis. And I want to get a PhD in epigenetics. I know, I'm really a geek. But epigenetics is fascinating because for the most part, our genes, except in a classic pathological mutation, don't give us something. They give us a predisposition for something. But our question then is, that predisposition cuts both ways, positively and negatively. How can we harness our genetic material to change behavioral lifestyle factors to capture the epigenetics to make sure that it falls on the positive side of the spectrum rather than the negative side of the spectrum? And we do this every place else. If your parents died in their 50s of cardiac disease, when you go see your physician, they don't say, oh, sucks to be you, wait for your cardiac event at 54. They say, let's monitor your hypertension, let's keep your lipids down, let's get you exercising, let's get you eating right. And in reality, the data show we have now delayed onset of cardiac disease in those people till their 60s or 70s. And even when they have it, it's far more treatable, right? Diabetes. Okay? My father had type 2 diabetes. My older brothers have type 2 diabetes. But they're overweight. Their idea of exercise is they do one sit-up a day. They get up in the morning, that's a half, they go to bed at night, that's another half. One brother thought he had exercise. He took an antibiotic to get rid of it. I run, I bicycle, I do these things because I don't want to get to that point. I don't want to be diabetic, so I don't have cellulitis. I don't have type 2 diabetes. I don't have pulmonary problems. But my parents swear I'm not the same genetic makeup. I believe them. My dad, my mom, Yes. I can say that about my dad because he's dead, so he doesn't care. So we can use epigenetics. Now, here is where I said I want that PhD in behavioral economics. What we have to understand is all of our data right now shows that what we're dealing with in our 70s and 80s begins in our 20s. In fact, there are now studies, remember that amyloid that we're talking about? Northwestern University has started to show an accumulation of this amyloid in folks in their early 20s, going back and looking. So this is starting very, very early on, which means we need to start early on. Now, that is not licensed if you're over 20 to say, well, too late, sucks for me, I'm not going to do anything. Just means the sooner we start, the better, right? Now, what can we do? This is the take-home message for all of us. First of all, manage vascular factors. If you have strokes and you have a bad heart, your risk for Alzheimer's disease goes up because we're not getting blood to the brain, we're not getting toxins back out of the brain. Bad things happen if you have hypertension and it's not managed. Bad things happen if you have sleep apnea and it's not managed. So manage vascular factors. Manage sugar, diabetes for reasons we just talked about. Don't get yourself to the point of type 2 diabetes because even if we manage it, something bad is happening in that brain and it's not the diabetes that's going to be the problem that you worry about. Okay? Now does everybody, am I saying diabetes causes Alzheimer's? No, I'm not. I'm saying it's one more risk factor that we have to a large degree, unless you're a type 1 diabetic, a large degree of behavioral and environmental control. That makes sense? Avoid closed head injuries, concussions. Duh. Okay. Yeah, never good to have a head injury, right? But here is where we're talking to younger folks saying, okay, think about what you're doing in sports now, because even if it's not an issue here, it may be an issue for you 30, 40, or 50 years from now. This is a huge thing in the NFL studies right now, right? Okay. I knew Junior Seau very well, who died of what we call chronic traumatic encephalopathy. I watched him go from being a very functional, very bright man. And you can tell me that CTE doesn't exist. I saw it in Junior Seau. His family lived with it. I've seen his brain scans. Something bad happened, and he's not a drug abuser. He's well educated. He doesn't have Alzheimer's in his family, but a series of getting his head beat up on a regular basis did something to him. What else can we do? Let's look at the things you've all heard about. Statins. Okay, put you on a statin, keep your cholesterol lower. Does it help? Yes. No. Alzheimer's disease is like cancer. I remember I started off earlier by saying Alzheimer's related diseases. We have to stop thinking about Alzheimer's as being one thing. It is likely a spectrum of things. And for some people, cholesterol and cholesterol metabolism and fat metabolism probably plays a very significant role, but depending on your genetics, it may play less of a role. But bottom line is control your cholesterol, because if you have other vascular problems, you're going to be in trouble anyway, right? So it's probably not the statin directly for most of us that's going to be helpful, but it will be helpful secondarily, and you might be lucky, it may even help primarily if you're in that role of genetics where where cholesterol and lipids are playing a role. How about vitamin E? How many of you are on vitamin E to stop your Alzheimer's disease? Yeah, be on it. I don't care if you're on vitamin E, but we now have data showing it doesn't really change your risk for Alzheimer's disease. Omega-3 and omega-6 fatty acids. Yes, particularly the 3s. If you're not on 1,000 to 1,200 milligrams of omega-3 fatty acid from fish oil source every day, shame on you. Sound like a Baptist preacher. 1,000 to 1,200 milligrams is what we recommend for most adults. Now, if you've ever tried to take an omega-3 fatty acid like the Costco capsules, they are so large, unless you are 2/3 the size of an elephant, or you go through an expanding of your throat, or you don't want to eat for the next 3 days, I don't know how you take them, because they're gargantuan. The bigger issue is if you take it in that form, you probably aren't going to get much usable omega-3 fatty acid, because we're not designed to absorb oil. What did our grandparents use cod liver oil for? A laxative. So you're going to poop out most of your omega-3. You'll be regular. That's good. But you're not going to do much for your brain. This is not an advertisement for Barleans that's being recorded, so please, I get no kickback from Barleans. I like the Barleans brand. because it comes in the form of a yogurt, so it's like a yogurt. It's not actually a yogurt product, but it's the consistency of the yogurt. It comes in a food source, so when the food source is absorbed across your intestinal lining, it takes the omega-3 with you. We see really high absorption rates. It's the way I take mine. I like it because it comes in 5 flavors that taste good. Okay, it comes in lemon meringue, blueberry. Somebody said they found it in like a strawberry kiwi. Even better thing is it's affordable. Rosars carries it, your food store does, natural grocers does, and Costco does 3 or 4 times a year. You know how they carry things on cycles and you can pick them? So whenever we're out there, we just look for it if it's there. We buy 2 or 3 bottles because it'll store forever. Stick it in a cool, dark place and it'll be there 6 months when you come back. Just refrigerate it once you open it.
What's it called again, I'm sorry?
Barleans is the brand. I think the brand, well, the manufacturer is Barleans. It goes by different names. Omega Swirl is what I think it is when it's carried at Costco, if I recall. Is that correct, Sean? Am I right? I just like the taste.
Is it a liquid?
It's like it's almost like a thinner yogurt that you squeeze out of the bottle. Yeah.
Oh,
Nordic Naturals also has a brand that's really pretty good. It's more liquidy, but it's got more of a fishy aftertaste to it. But I used to take the capsules and I felt like I was a seal. I had fishy indigestion all day long. And cats were following me wherever I went. And I don't like cats, so you can see why. Non-steroidal anti-inflammatories, not clear. What we do know is inflammation is playing a role. So one more factor in Alzheimer's disease. NSAIDs probably help, well, for the same reason we see autoimmune factors. We're just not quite sure what the role is. But we don't generally tell people to get on non-steroidal anti-inflammatories at this point in time because there's some other problems with long-term non-steroidal anti-inflammatory use. But if you're on one and you have to be on it for another reason, then maybe it'll provide you some benefit. Now, anti-inflammatory issues, definitely we want to focus on. We're just not sure NSAIDs are the way to do it. Wine use, getting to my favorite part. Yes, question back there.
I don't see vitamin D up there. Have you seen some of the lowered risk studies with adequate vitamin D?
Yeah,
Say like 50 to 60 nanograms?
We'll talk about that in just a little bit. Both vitamin B and vitamin D do have some research supporting it. B6 and B12 both are involved. D does. Again, it looks to be genetic related. It seems to help one sample and doesn't help the other samples. But not a bad thing to be on, and you're not going to overdose on vitamin D, so not a bad way to go. Now, wine use. Wine use. This does not apply to Scotch. It does not, unfortunately. It does not apply to gin, but I think God created gin and water to look alike for us. But this is wine use. No, well, I cannot say that. Beer now is getting some supported data, particularly IPAs. So if you like IPAs, maybe. But we don't have a lot of big data on that. Most of the data is on wine use. Now, having said this, I do not recommend to my patients, if you don't drink wine, start drinking wine. Okay? What this is, if you're already drinking wine, it probably has a modest protective benefit. It seems to block the aggregation of beta amyloids, and it seems to reduce the toxicity of existing plaques. So when there is a problem, it seems to be blocking that from causing another problem. And that's what happens in neurons, is when they die, they release these things that then result in other cellular damage. That's why if you've seen the billboards around, if you have a stroke, they want to get you to the hospital right away to see if you're a candidate for what we call TPA. The whole purpose of that is to keep downstream problems from occurring from the stroke. You still have your stroke, but what most people don't realize is the morbidity of strokes usually isn't from the bleed itself, it's from all of the things that happen after that bleed that we're trying to keep from happening. And that's probably what's happening here. Cinnamon seems to have some increased supporting data. This is getting a lot of attention in New Zealand and Australia right now with good studies. Turmeric, the active ingredient curcumin seems to be involved with it. We don't know what roles they're playing, but we certainly are seeing some protective data. So if you like cinnamon and you like Indian food with turmeric, seems to help. Extra virgin olive oil, the oleocanthal, seems to be helpful in terms of blocking amyloid. All of these are helping with amyloid in some form. So again, we know what's involved, we just don't know how. Now the key here with extra virgin olive oil, I don't know if you've seen the like 60 Minutes and so on and so forth. Most extra virgin olive oil in the United States is not extra virgin olive oil. It's actually a very contaminated product. So to get it, you're gonna have to get a supplier either online or go to the good food store, because it's a huge industry. It's actually larger than drugs in Europe right now. It's basically taking extra virgin olive oil and cutting it with things, and then it goes across the pond, and we're all buying it, but it's got some nasty meaty stuff in it, so make sure you know who your supplier is for all of that. That's all I'm saying. Yes?
How much wine is the beneficial?
Nice. Now, the important question. As I tell my wife, 2 glasses a day, and she says that's 2 60-ounce glasses.
Right.
No, dear, that's not the case. Premenopausal women, 1 glass a day, 6 to 8 ounces. Premenopausal men, yes, men do have menopause, 2 6 to 8 ounce glasses of wine. Postmenopausal women, up to 2 6 to 8 ounces of glasses of wine a day. And we don't get more by getting older. 6 to 8 ounces seems to provide benefit. You go beyond that, you lose. You don't get any more protective benefit for your brain, and the impact on the liver then offsets any of the
Could you
benefits.
repeat that for those of us who carry that?
Postmenopausal women can have up to 2 glasses of wine a day, and it seems to be beneficial. Premenopausal women up to 1. Men, either any age, up to 2 glasses of wine a day seems to provide some benefit. Red's the only thing that really works. White wine doesn't have enough of the flavonoids in it. This is held in the skins of the grapes, so the longer it's with it. They are trying to find a way to get in capsule form, and there have been a couple manufacturers that have done that. But interestingly, the studies have not borne out that it's been helpful. So there seems to be something between the alcohol molecule in the wine, or there's something in how whatever else is in the wine, other than that active ingredient, is resulting in its absorption or metabolism that's useful.
But drink white wine and take one of the capsules together.
Any calorie. I'm mum on that. So there's your wine. I have a good friend that he's not a clinician, but he's an IPA drinker. And the study on IPA beer, I swear, had no more finished coming off of someone's pen. And he sent me the article.
Yeah.
All right, all works for you. Diet. This is huge. Okay? Bees we talked about. You're going to hear about the Mediterranean mind diet here in a moment, but a combination of B vitamins seems to be helpful. D, yeah, not as much as B's right now. We've already talked about the omega-3s, but blueberries and strawberries, particularly blueberries. I strongly recommend a ½ cup of blueberries a day if you want to reduce your risk. Again, something about flavonoids, but again, something about the way it's coming through in the blueberry itself. Blueberry juice does not seem to be giving us the same protection. Blueberry extract does not seem to be giving us the protection. I'm not a natural food eater, okay? It's not like I'm eating some natural food, organic, holistic kind of drama. If you saw my diet, you'd realize that ain't me, as I'd say in Montana. But there is something about, we're going back to the whole foods that the good Lord gave us, and they seem to be providing us the greatest protection. The more we are processing this, seems like the more protection we're losing, so take it for what it's worth. I ain't making it up, it's just what science is showing us so far. Now, mind diet. And I have a bunch of handouts on the mind diet that I'll have up here if you want to look at it. You've all heard of the Mediterranean diet, right? You can't read a book without, or a magazine, or turn on the TV without. The Mediterranean diet cures hangnails, hemorrhoids, Alzheimer's disease, you name it. It'll cure your dog if you put them on. And the Mediterranean diet is a great diet if you live in the Mediterranean. If you try to do the Mediterranean diet in Montana in the winter, good luck. It's hard to do. But the other problem with the Mediterranean diet is we find it offers great protection, but only if you're almost 100% adherent to it. And I don't know about you, but I'm not that disciplined. So the mind diet is what is now out, and it's been researched for about 30 years now, and it's a cross between the Mediterranean diet and what's called the DASH diet, which has been around since the 70s for hypertension. But what's impressive about this is that people who were fairly consistent in a study, dropped their risk for conversion to Alzheimer's disease by over 50%. Those who were only moderate adherents dropped it by a little more than a third. If we had a medication that I could sell you today that said it would reduce your risk for Alzheimer's disease by a third to 50%, you would give me anything you had in your, I'd take it. This is a huge effect size by doing nothing other than changing your diet. Lecithin, another flavanol is in there. This is the one I want to get to. Intermittent fasting may be protection. Remember how we said insulin's involved? There seems to be something about an occasional one-day fast that resets the glucose metabolism system and can be helpful. I think in general intermittent fasting is good biologically. Now, if you're already eating very healthy, if you're following the MIND diet pretty closely, or you're following the Mediterranean diet, looks like we don't have any additional protective benefit from the intermittent fasting, but if you're not, that intermittent daily fasting looks like it can be beneficial. Now, you have to be thoughtful about this. If you have hypoglycemia, you have diabetes, no. Okay? I've got enough fat on me that I can go more than a day, and trust me, I am not going to run out of biological energy reserves. But if you're one of these folks who doesn't have a lot of fat on you, then again, don't do an intermittent fast. Okay? It's not good. Most of us, however, the average classic Montanan, we ain't going to die. Okay? And it does seem to provide some benefits. So unless you have a medical contraindication, fine. But if you're doing a good diet, go for it. Seems to basically increase the production of what we call BDNFs, which are responsible for cell repair and metabolism.
What do you mean by intermittent?
Good question, and nobody knows because they haven't done a lot of comparative studies. What I tell people is every 3 to 4 weeks, probably great to have a day. It doesn't have to be very
24 hours?
frequent. Yeah, no, just for 24 hours every 3, 4, 5, 6 weeks. I've seen studies that have done it every 6 to 8 weeks, and they found pretty good results. I've seen some studies where they did it every 3 to 4 weeks. They had good results. I saw one where they were doing it weekly. There was no additional benefits. So it seems like it's kind of a threshold thing.
And do you recommend like tea, drinking tea, or
Yeah, still hydrate.
water?
Yeah, but just not a lot of other nutrients. You can do tea, you can do water. I wouldn't recommend a lot of real heavy caffeines, but otherwise you'd be fine. And the other thing is, there's some data that suggests it doesn't have to be a complete fast. You can still have a little bit of food throughout, but if you're cutting down, so your brain's having to figure out how to basically turn on the fat metabolism cycle, that seems to be what's really helpful here as best we can tell. Now, more importantly, exercise. Exercise, exercise, exercise. I don't care what you do to get your body moving. Exercise is showing it is beneficial. Earlier the better. But anytime works. The Mayo Clinic, you can see we got a 32% risk of moving into mild cognitive impairment, which we think might be a precursor to that Alzheimer's disease. But notice this is moderate exercise 5 or 6 times a week. Okay? So it is frequent. What I tell people is shoot for 6 days a week, that way you will get 5. Now, you still get benefit at 3 or 4. If you say, oh, I can't do that much, I can only do 2 days a week, then do 2 days a week. You're going to get benefit. It's just that this study used 5 to 6, and it showed a pretty nice response rate. Now, what does moderate exercise mean? Moderate, you can buy a heart monitor if you want, but you certainly don't need to. The best way to think about moderate exercise is if you're doing it and you have somebody next to you and you're carrying on a conversation, the conversation will be somewhat labored because you're having to gasp for air. If you're walking at a leisurely pace and you're carrying on a conversation like this, that's not moderate exercise. I hate to break it to you. Now, still good for you. Any kind of exercise can be helpful, but if we want to help the brain, it does look to be at that moderate level. Females benefit from longer duration than do males, but anything that you can get, you don't have to get fancy about this. Park a little further away from the grocery store and try to walk in a little faster. Anything that you can do is going to be helpful. Weightlifting seems to be helpful for isometrics. I tell people mix it up a little bit. We certainly want that subaerobic activity, but there also seems to be benefit from weightlifting. The data aren't real clear on that. We saw in women who we had do weightlifting actually had improved neuronal growth, but no change in cognition associated with it. I think that was merely a matter of some measures. What we do know is that if you're doing isometrics or weightlifting, you're breaking proteins loose, and neurons are made of proteins, so it's a good thing to do. Okay. Exercise more here on women, we don't need to meet that. Cognitive activity, stay cognitively active. I don't care how old you are, if you can't get out of the chair, you can stay cognitively active. The old adage our grandparents used to use it or lose it, has never been more true. This is one of the most exciting areas right now. I've already decided I will not retire. I'll change the way I practice. I'm in practice for a week, take off for a week, practice 10 days, take off a week. But I will stay active. Why? Because I'm not disciplined enough to keep myself cognitively engaged if I don't have something that keeps me cognitively engaged. Now, other people are different ways. They could do it. They could go do volunteer work. But I know what I'd be doing. I'd be fly fishing and trying to convince myself that it's good for my brain. And it probably isn't, but it's not going to help with my Alzheimer's. So try to stay cognitively active. How do you do that? Velocity, cognitive, aerobics, playing games, reading books. I tell people, make a goal to pick up 2 foreign words, language words a day. Pick up a language you want to learn and just try to learn 2 words a day. That cognitive activity increases dendritic density and maturation, and it's going to be helpful. Pick up a new hobby. Just intentionally do something. When my dad was older and he couldn't do a whole heck of a lot, but he loved watching the History Channel, I said, Dad, just when you're watching the History Channel, take notes so you actually have to process it. It wasn't 2 weeks later he called me and said, you know what you're talking about. I was like, thanks, it took this long to get there. I don't know. 2 PhDs and a master's later, and you finally think I know something. Thank you very much. But just using that brain is what we need to be doing. So you put exercise together, diet together, some supplementation together, and cognitive activity together. Suddenly we're starting to get a lifestyle change that's probably pretty important here. I'm not going to go in the religious order study. I want to go to this one. Age, genre-specific music. Listen to music of what you consider your formative years. So I consider the 70s my formative years. That's when I was listening to music, right? I was born in '62, so 70s is when I was listening to music. When my kids are over or they're in the car with me, I've always got Sirius Radio XM 70s on 70 going, and I'm quizzing them. Okay, who was the lead singer of that group? When did they come? Where are they from? What was their first song? Blah, blah, blah. And they're like, Dad, you're driving us crazy. Why are you doing this? Because I'm not going to let you choose my nursing home. I know your mother. But that music is important. And why is music important? For one simple reason that is very complex. Music and olfaction, smells, seem to access our memory centers via completely different routes than the rest of our cortex. But by opening up those memory vaults, it's like a drawer that's rusty. The more we open it, the easier it should then open, right? Think of it this way. If I asked you to give me the lyrics to a Christmas song right now, you probably couldn't come up with it. But if I started to play the Christmas song, you'd hear the first 2 to 3 notes, and immediately the lyrics would come to mind. I went into somebody's house about 2.5 weeks ago, and I smelled cinnamon rolls that smelled just like my Grandma Sutherland cinnamon rolls, and I could see the inside of her house at 613 North Center in Miles City, Montana in the early 70s, as clear as the day was, including the pink walls. Because music and olfaction do access memory via completely different routes, so take advantage of that. Deep brain stimulator, some studies suggesting that. It's too early to show much, and it's a surgical procedure, but it may be helpful in the future. Social support, stay socially active. Disrupt your routine in a fun fashion. The more things change, the better you're going to be in terms of reducing your risk. And then use new daily life technology. Learn how to use smartphones, older people. And I have to do this as well. I mean, things keep changing. Don't stick with what you're comfortable with. Mix it up. Let me shut up. We're almost out of time. I want to answer questions. So questions, and I'll also hang around for a little bit. I've got a lot more to do, but we've got to move. Yes, ma'am.
You said the one diet that would reduce your risk of Alzheimer's by 30 to 50%. What is it?
Mind diet.
I've got handouts. It's basically what to eat and what to avoid. It's heavier in nuts and some good fats and avoiding red meats. But what I like about it is I'm a Montana boy who was lucky enough to come back. I will die with red meat in my mouth, okay? If you said, Valine, you've got to stop eating steak and prime rib or you'll have Alzheimer's disease, I'd say, I'll forget I ate and had it all over again. There's an upside to everything, right? You got to find a positive side. So this thing, use it as, I tell people, use it as your framework and then add what you're going to add to it because you get benefit even with moderate adherence. But I've got a handout that shows you what, kind of a basic outline of what it is that you can pick up here. And you can go online and you'll find all sorts of stuff that's been done on this up to date. But it's not all that hard to keep up with. They're up here if you want to get them. Other questions? Yes?
So where would you suggest that a family goes to for help with somebody that has Alzheimer's in communicating with them, in your relationship with them, in, you know, their care, when they're not in an assisted living, they're still married, they're still together, they're still living on their own, but you know that there's probably dementia issues, and so you need, family needs help?
Yep. Talk to your primary care physician, go to Missoula Aging Services and Jackie Johnson, where Jackie Johnson runs the Alzheimer's disease support groups, and they have all sorts of information. The Alzheimer's disease Association has a great website with all sorts of great information on it. It's important to not feel isolated. There are folks and resources out there. If you get hooked up with a neuropsychologist, we're going to be making sure you get hooked up with those organizations and you follow up. But there's a lot of them that are just broadly available in the community.
One of the things that you talked about with the self-reporting is the self-denial.
Yep. Yep. No, I'm sure Jackie would be able to attest to this, but boy, in San Diego, I helped facilitate one of the Alzheimer's disease support groups, and we had more spouses in there of spouses who clearly had a dementia that were not willing to accept that they had a dementia, and the support group was not for the person with Alzheimer's disease, it was really for the family and the supporting groups. Johnson, and I think she probably has some cards here that she can give you as well. It's a great resource. The Alzheimer's Disease Association's got some great handouts and resources. Definitely take advantage of those. And what I tell people, with Alzheimer's disease, if you're really sweet to begin with, you're going to become more sweet. If you were kind of irascible to begin with, you tend to become more irascible. So my mother, she has gone from being one of the most beautiful women in the world to an even more beautiful woman in the world. She may not remember how to get to her room, but she is still as lovely as she ever was. I am so glad my dad died before he developed Alzheimer's disease, because it would not have been pretty. God bless him. Loved the man to death, and he was a generous, lovely man, but he had his irascible side.
I'm wondering about screening tools for primary care.
Screening tools?
Do you have any that you recommend?
Montreal Cognitive Assessment is one of the better ones, the MoCA. The Mini Mental Status Exam, which is what most of them use, has good sensitivity but very low specificity. It basically doesn't catch you until you're well too far along. So the MoCA, the Montreal Cognitive Assessment, which doesn't takes a little longer to give, probably 15 to 20 minutes if you're pretty good at it, is what I recommend most folks use, because it has good sensitivity, pretty good specificity, and you can repeat it as they move along. If somebody's positive on that, that's when generally we're going to get you into neuropsych and do a MADIS, dementia rating scale, and some other measures. And that's particularly important, and particularly for women, because what we also know is women tend to get diagnosed later, particularly bright women, because they're often very well developed verbally, and so even though they're having decline, they don't get enough decline for somebody to pay attention to it until it's too late. And this is like rust. We really want to get in there early. I want to see somebody in the MCI stages when I can, or before that. I'm working with an organization right now that is, the venture capitalists are out of Florida and Georgia. We're literally going to be trying to develop communities to get people in their 50s and 60s living in and engaging in these lifestyle kind of things long before they ever get to MCI, so they never get there in the first place. I think there's a huge need for that.
And another question, in terms of differential diagnosis for the various types of dementia or categories of dementia, how important is that in terms of, say, treatment with medication?
Very. Not so much medication, because none of our medications are very effective, but if we have a vascular dementia or multi-infarct dementia, really what we're going to manage predominantly is just that hemodynamic vascular side of the things. There's not a lot of other things that we'll do, because that shouldn't progress a lot as long as we keep the vasculature fine. But if we have something that suggests we have more of a progressive course, like Alzheimer's or FTD, a lot of different things we do. And frontotemporal dementia or FTD, really different and really big for the family, because we're often working very closely with the family, because these people, long before they have memory impairment, have behavioral disturbance. These are the folks that'll walk outside in their underwear because they lose judgment. So I saw a man 3 weeks ago who, very prim and proper his entire life, but the family who doesn't live around started getting calls from the neighbor saying, you know, in the last 2-3 months, he's been walking outside, it'll be snowing, and he'll be outside in nothing but his boxers. And one day he walked out in his robe, but he didn't have anything else on, and he's kind of waving to kids. And this is just totally uncharacteristic of him. But his kids are talking to him on the phone. His memory's still good. He's carrying on conversations, but that judgment kind of goes down. Well, there we're having conversations about now how are we going to manage the memory, but how are we going to make sure he doesn't get into some other sort of trouble. So.
In terms of the interface between you and primary care providers, because I think a lot of patients go back to them, are you having this conversation with them?
Yeah, I'm very fortunate. I have a very good relationship with the vast majority of primary care. I'm one of the old farts now. I've been back here for 24 plus years, and so I'm part of that group that has kind of grown up together, and I have really good relationships with the vast majority of family practice and internal medicine and the VA and elsewhere, and we all kind of coordinate together. So I'm getting my reports back, and I'm saying, here's what you need to do on your end, and here's what else we need to try to hook up, and here's what we're doing. And so we try to coordinate all of that. But there's a lot of communication that goes on. And I've got a clinical coordinator that that's probably 60% of her job, is making sure that that kind of communication goes on. Is it perfect and are we good at it as we'd like to be? No, and we'll work on that till the day I die, but we sure try. That communication's essential. Other questions? Yes.
Only briefly touched on it, but the inflammation response seems to be a pretty big public media source of many diseases right now. And I'm specifically thinking of Dr. Perlmutter's book.
The brain game, the grain brain, and all of those. Yep. No, those are great sources. The one model that I said we're looking at is really using a lot of his data. I really think that there is an inflammatory issue that's going on in our system, which is probably the trigger which sets off a lot of these other things. And as I said, I've kind of given up on the cure of Alzheimer's disease because I think it's too complex for us to cure. I'm now starting to shift my research and clinical interests to prevention because it's a whole heck of a lot. It's still complex, but it's going to be a much better thing than waiting for a cure to come out over here. So.
And the whole inflammatory response really does start with the lifestyle changes.
As best we can tell right now. Yep. But, you know, somebody has RA, rheumatoid arthritis, or another autoimmune disease, and we're going to make sure we manage that very well, not only with lifestyle issues, but other things. That's when somebody may be on a non-steroidal anti-inflammatory or something else to try to reduce that ongoing inflammatory process. Yep. Other questions? Yes?
One of the buzzwords that's going on in your field in the last, say, 15 years has been plasticity.
Yep.
Does that add to or take away from this dementia? Or this?
Adds to. That's why we're talking about the epigenetics, which is our genetics give us a predisposition, and now we're going to alter the way that manifests itself, and we're going to capture that neuroplastic process and use it to our benefit rather than letting it go the other direction.
That ties it together.
Yep.